Good evening, everyone. Thanks for joining us virtually tonight. My name is Leah Rutman, and I am the Healthcare and Liberty Counsel at the ACLU of Washington. I'm excited to welcome you to our special Flights and Rights on the Future of Healthcare in Washington State. Before starting tonight's program, I want to acknowledge that I am speaking from the traditional land of the First People of Seattle, the Coast Salish people, who have stewarded this land for generations. I also want to give a big thank you to our wonderful co-hosts who helped plan this evening. The American College of Obstetricians and Gynecologists in Washington State, Cedar River Clinics, End of Life Washington, Legal Voice, NARAL Pro-Choice Washington, Planned Parenthood Votes Northwest and Hawaii, and Planned Parenthood of Greater Washington and Northern Idaho. All of these organizations are doing incredibly important work to ensure everyone in Washington State and beyond has access to the care they need. We're including links to all these organizations in the chat if you want to check them out. I highly recommend it. So on to our main program for the night. Before we get started, we were going to actually give you all a little poll just to start things off in a fun way. So I think right now a poll is going to show up on your screen. Please take 1 minute to fill it out. It should read, does the healthcare facility you normally visit provide the full range of reproductive, end of life, or LGBTQ+ care? Yes, no, or I don't know. We're going to give everyone 1 minute to fill that out. Okay, I think we're going to close it out now. And the main result, the most common answer was, I don't know, and then yes, and then no. So I don't know is a very common result we hear when we get that type of question, when we ask that type of question. And the reason it's relevant tonight is tonight we're going to talk about barriers to care. This has been a tough year, and COVID-19 has laid bare the innumerable inequities that exist in our healthcare system, and so many different ways people can experience barriers. Tonight, we're going to talk about a very specific barrier, health system restrictions on access to reproductive and end-of-life care, what we can do about it. So by health system restrictions, what do I mean? It means that there are health systems like hospitals and clinics in Washington State that have policies that prohibit your doctors or nurses from providing you with the care you need. This may mean you aren't able to get a sterilization procedure like a tubal ligation. It may mean your doctors aren't able to help you if you're terminally ill and seeking medical aid and dying. It may mean that certain fertility treatments aren't available to you. And it may mean that even if you're miscarrying or have an ectopic pregnancy, your doctors won't be able to treat you. Catholic health systems are a good example of these type of restrictions because Catholic health systems are required to abide by the ethical and religious directives for Catholic healthcare services. These 77 directives, which are not written by doctors, but by the Conference of Catholic Bishops, put significant restrictions and prohibitions on reproductive and end-of-life care services, including contraception, vasectomies, fertility treatments, death with dignity services, tubal ligations, the list goes on. Adherence to the ERDs may also increase the likelihood that LGBTQ+ individuals and families will face discrimination in seeking to access healthcare services. This is a really significant issue in Washington State, as Washington has become an epicenter of religious secular health system affiliations. In 2010, 26% of state's hospital beds were in religious or religiously affiliated hospitals. If a recently proposed affiliation between Virginia Mason and CHI Franciscan occurs, that number would rise to above 50%. So over 50% of the hospital beds in Washington State would be in religious or religiously affiliated health systems, with some counties being serviced only by these systems. The impact also extends far beyond hospitals. It includes medical clinics, physician offices, hospice, and laboratories. The end result is your doctor or nurse may not be able to provide you with the care you need, not because they don't have the training, the ability, or the willingness, but because of restrictions placed on them by the institutions they work at. One question you may be asking yourself, if you happen to be a lawyer like me, is don't we have some pretty great laws in Washington state? Isn't there something in them that can protect us? So we do have some great laws, especially when it comes to healthcare access. We have a fundamental right to abortion and contraception, and terminally ill patients have the right to request medication to end their life on their own terms. Unfortunately, none of these laws are stopping health systems from restricting access to care. That's why we need to pass new laws. Many of the organizations sponsoring tonight's event are working to pass the Protecting Pregnant Patients Act. This bill is a very targeted bill addressing miscarriages and ectopic pregnancy. It would ensure that health systems could not prohibit willing and qualified doctors and nurses from providing care to patients when they're miscarrying or have an ectopic pregnancy, when there's a serious risk to their life or health. Similarly, many of our organizations are working to pass a bill that would require governmental oversight of health system consolidations, so that government regulators can review these transactions to ensure that when these consolidations occur, communities aren't losing access to the services they need, including reproductive, end-of-life, and LGBTQ-related care. We have created an online toolkit that you can find in our chat. We'll put it in now, and then we will also include it later. The link that you will find will lead you to a webpage that includes an action alert to lawmakers. We strongly encourage you to fill that out if you care about this issue. It lets you send an email to friends and families telling them about this issue and asking them to send the action alert to educate and activate them. It asks you if you have a story to share with us about not being able to access healthcare, and gives you different ways to, on social media, put this issue forward and educate the public. We hope you check out the toolkit, and I'll remind you about that at the end again and ask you if you're interested to fill out the action alert. Now let's get on to our program. We have 4 amazing panelists with us tonight. They are made up of healthcare providers, patients, and health volunteers who will share their stories, expertise, and experience. And I am so grateful to have them with us today. First, I'd like to introduce Dr. Laura Siennis. She's a maternal fetal medicine specialist in Seattle. She's here representing ACOG, the American College of Obstetricians and Gynecologists. She went to medical school at Creighton University. She did her obstetrics and gynecology residency at the University of California, her maternal fetal medicine fellowship at the University of Washington, and her clinical and research interests include cardiovascular disease in pregnancy, prematurity, environmental exposures in pregnancy, and severe maternal morbidity. I now want to introduce Caitlin Lombardi. She is a community engagement and social impact professional living on Bainbridge Island. She's a lifelong resident of the Pacific Northwest, and she has 2 young daughters and a 3rd one on the way. She is always happy to speak out when equity and justice are on the line. Next, I'd like to introduce Dr. Wayne Dodge. He is a lifelong Washingtonian, other than a dozen years in educational exile on the East Coast, his words, not mine. As a family practitioner and geriatrician, he practiced at Group Health. In the 1980s, he created and ran the HIV program for Group Health until his retirement in 2012. His experience with primary care, and in particular HIV, convinced him of the importance of the option of death with dignity. He has worked with End of Life Washington for the past several years as an attending and consulting physician, and is now picking up some of the work of the volunteer medical advisor. He received his Bachelor of Science from Yale, his medical degree from the University of Rochester. He did his residency at Case Western University and his MPH at UW. Lastly, but definitely not least, I'd like to introduce Cassandra Sutherland. She uses she, her pronouns and resides on occupied Duwamish lands in Seattle. Her work has taken her across the globe from Paraguay to Rwanda, and she earned her master's degree in global public health from the University of Washington. After supporting her dad achieve his own death with dignity, she joined End of Life Washington as a client service manager. When she isn't supporting people at the end of their lives, you will find her spending time with her wife and dog. Thank you all for being here. I think this is a really fantastic panel. As an initial point, I'd love to start with Dr. Siennis. And Dr. Siennis, as we could tell from your bio, you have a lot of experience treating pregnant patients. And as an advocate, I hear in my advocacy world that there are restrictions being put on these patients, that patients who are miscarrying and experiencing ectopic pregnancies are going in and not receiving the care they need. I don't see it on the ground. I think I'd love to hear from you. What do you see on the ground? What is happening in reality in Washington State?
Yeah, thanks for having me, Leah. So, as a maternal fetal medicine specialist, I specialize in taking care of complex high risk pregnancies that either have a maternal health issue or fetal complications. And as a provider for a large hospital system in Seattle, I'm the consultant for various general OBGYN providers across our state, as well as a safety net hospital for those patients. Unfortunately, through this role, I have learned that all care is not equal in our state. It shouldn't matter if you live in a small town in rural Washington or a large city, patients should have access to safe and medically established standard of care treatments for their pregnancies. This is not a rare occurrence, despite what some people might say, and complications in pregnancy often occur with providers being put in a difficult position of not being able to offer the evidence based treatments to help care for their patients. I have many examples of this, but I'm just going to share a few stories tonight. So, the first patient I want to tell you about was having an uncomplicated pregnancy until she broke her bag of water early at 16 weeks and developed a severe infection in her uterus. When this occurs, the recommendation is to give medications to help remove the pregnancy tissue to decrease the risk of that infection spreading into the bloodstream. At her hospital, she was told that she was unable to get those medications because at the time the fetus still had a heartbeat. After many hours, her physician was able to transfer her over 3 hours away to Seattle to complete the procedure. Unfortunately, the patient's infection did get worse in that time, and she needed both prolonged antibiotics and had increased bleeding at the time of her delivery. In extreme cases of this situation, the patient needs to have a hysterectomy or removal of the uterus to control the infection, and that risk definitely increases the longer the patient stay pregnant. As you may know, 1 in 4 pregnancies end in miscarriage. Often, women in the first trimester get some cramping and then some bleeding, and the pregnancy passes without any needs for intervention. But if all the pregnancy tissue does not pass, a woman can have really heavy bleeding and need to get the rest of the tissue removed to be able to stop that bleeding. One patient went to the emergency room with severe cramping and heavy bleeding during a miscarriage. Her doctor needed to complete a short 5-minute procedure to be able to stop her bleeding. But since the fetus still had a heartbeat, her doctors were met with resistance from the hospital administration. After many hours, the doctor was actually able to complete the procedure, but in the meantime, the patient had so much bleeding she needed a blood transfusion, which again comes with its own risk and complications. I can keep going on about stories that are very similar to these, but knowing that this is actually a really common complication that happens in pregnancy, and we want to make sure that across the state, people are getting the standard of care treatment.
Thank you so much, Dr. Siennis. One follow-up I have is I mentioned in my intro that many of the organizations co-hosting this event, including the ACLU and others, are supporting the Protecting Pregnant Patient Act. And what that bill does essentially is ensure providers like yourself are able to treat these women irrespective of health system institution policies. They wouldn't be able to prohibit you from doing that. ACOG has been one of the foremost advocates of this bill. Can you talk a little about why that is, why this is such a priority issue for your organization?
Sure. Yes. So ACOG strongly supports this bill. It's important that the patient doctor relationship is preserved without restrictions, and physicians are allowed to provide all options that are safe for patients. Physicians and hospital staff should not have to worry about if their job's going to be at risk if they put patient care first. We all take an oath to do no harm, and delays in care of not being able to provide the standard medical treatment can lead to catastrophic complications. If a patient's in a medical emergency, she shouldn't have to worry about which hospital an ambulance is taking her to and does it provide that full scope of care. As you've heard, often these stories are tragic and stressful, and patients shouldn't receive substandard care and possibly increased complications because their doctor is not allowed to practice standard care of medicine. This bill would help protect providers to treat patients first and allow the women of Washington to receive comprehensive care wherever they live.
Thank you so much, Dr. Siennis, and thank you, ACOG, for coming tonight to support this bill. And Caitlin, I'd love to speak with you next. So we are very grateful to have Caitlin with us tonight. She actually has a personal story, and Caitlin, I will leave it to you to share as much of that story as you're comfortable with.
Okay, thank you. Yeah, I'm Caitlin. I'm a few things, including a patient at Seattle Clinic for High-Risk Pregnancies. And I'll be sharing my story this evening to help kind of shed some light on what we're really talking about when we talk about access to care for pregnant women. It's an emotional story for me and maybe for some of you, so fair warning. But I'm fortunate enough to be speaking to you today as the mother of two amazing daughters with a third on the way in February. So it's important to me that I help spread information to other expecting mothers about my story. So my husband and I went through 3 years of disappointments and diagnoses before finally getting pregnant in 2015. Obviously, we were thrilled. Our family and friends were over the moon. And when I was almost 4 months pregnant, with no warning whatsoever, my water broke while I was at work. Similar, I think, to some of the stories that Dr. Siennis was sharing. I had no idea what was happening at all, but as I started to have profuse bleeding and then cramping, my heart sank and I absolutely knew that could not be normal. I rushed to the clinic. Luckily, I was very close by. I was in downtown Seattle in my office at the time, and I was quickly transferred to labor and delivery. My doctors there were incredibly passionate, compassionate, and moved as quickly as possible to keep me safe and protect my chances of carrying future pregnancies, thank God. But there was nothing to be done to reverse what had happened with that pregnancy, with something called Pprom, or premature rupture of the membranes, which, like Dr. Siennis describes, means something had caused the amniotic sac to break, and I had lost all of the amniotic fluid that I had. So there was zero chance that that baby would ever be able to breathe outside of the womb. It's hard to describe the feeling of being wheeled past the labor and delivery sign to a floor full of moms and babies when I had just lost all hope for that pregnancy. But when I hear stories about patients that were in the exact same position I was in, but were refused the care that they need and put through even more, I know that my story could have been much worse. And I'm so thankful that I happened to be at a facility that was willing to admit and treat me. The same doctor who helped me safely end that failed pregnancy also delivered my first child in 2016, and I saw her just last week for a checkup on my current pregnancy, which is going very well. But it's important to understand that the full spectrum of care, even for a very wanted pregnancy, must be the full spectrum of care. So lastly, I know it's a sensitive topic and that people aren't always comfortable asking questions, but I hope attendees tonight are comfortable asking me really anything about this experience and the treatment I received, because there is no reason that there should be any shame or embarrassment or lack of information available about what is, as we just heard from the doctor, a very common occurrence. So thanks for letting me share and ask away if you'd like.
Thank you so much for sharing, Caitlin. I do have one follow-up question for you. I know you spoke a lot about your experience and that you wanted to share this with others. Can you talk to us a little bit about why that's important to you, what you want to get across when you're sharing that story?
Yeah, I just think there's a lot of misinformation out there about what is classified as a pregnancy termination or an abortion versus kind of just the medical care that somebody may need in a given circumstance. And so, particularly in other states where there's, lots of proposed bans at certain times of pregnancy, my story is about a very wanted, a fought for pregnancy that got to 16 weeks, just past all the nausea and everything looking great. And I still needed a termination. And so I just feel it's really important to kind of talk about that and to take the stigma away from what that means and who needs one, and what, that anyone besides you and your doctor would know what was right for you in that moment.
Thank you so much, Caitlin. We're going to switch over to talking a little bit about end-of-life care, and then we'll go back afterwards to our wonderful participants. And I think I'm going to start now with Dr. Dodge. So Dr. Dodge, you are in the really interesting position of both being a medical provider who assists with death with dignity services, and also being a volunteer for End of Life Washington as a medical advisor. In that dual role, can you please tell us a little bit about the Death with Dignity Act? What is it?
Happy to do so, and thank you for having us. My appreciation to the ACLU, and always my appreciation to ACOG for the fabulous work that my obstetrician gynecologist cohorts do. So the Death with Dignity Act was passed by initiative in 2008, but was after several previous attempts starting in the 1980s to get a similar sort of legislation done. And it came into effect in 2009, so we now have over 10 years experience with implementing this particular law. And its design is to allow people who are at the end of their lives to select that they choose not to go through the natural process of dying, with whatever happens at that, but to choose their time of death using lethal medications that they ingest themselves. Now, I'm myself always get a little nervous when I hear about this, because that just sounds odd in some ways. So there are multiple protections built into the law to make sure that this is a thoughtful thing, not just something where someone goes, oh, I'm tired of this, let me go ahead and off myself. So within the law, there are multiple requirements. First is, this is not the decision of a single patient. It's not the decision of a single patient, their physician. It is the patient, their physician, and a consulting physician. So there have to be at least 2 certified physicians who agree that this individual has a life expectancy that is predicted to be less than 6 months, and that this person has the capacity to make a decision about taking such medications. So those are the requirements before we can even move ahead with considering prescribing the medication. So the person has to have the capacity to do this, as well as having 2 physicians who agree that they fit the medical criteria for a prognosis of no less than 6 months. With that starts the process when we have the initial consultation with the patient, but then we have to wait no less than 15 days, as stated in the law, before we can do what is called the second oral request. So the individual has to then wait from the first going, I'd like to go ahead and use these medications, to then waiting 15 days for a reconsultation before we can move ahead with that. A couple other details are, they also have to fill out a written request with 2 signatories, 2 witnesses to their signature. And all of this needs waiting times of at least 48 hours after they write the request for the prescriptions before we can actually write the prescriptions themselves. So again, here are multiple guardrails to try to make sure that this process is actually thoughtful and not something entered into without a great deal of consideration. So that's the outline of the law as it currently stands. The very guardrails put into place have actually created problems. So in hospice, now hospice is a well-recognized, well-available service to those people who are dying. and most people, I think, know about the availability of hospice. The average time between entering hospice and dying is 24 days. So here it is with the death with dying law, there's a 15-day waiting period. So this means that up to almost half of the folks would have already died before they can get through that 15-day waiting period, even if they could get into the whole process as easily as you can get into hospice. So again, here is one of the issues that was addressed now by the state of Oregon, in which they say if it is obvious that this individual will die in less than 15 days, the 15-day waiting period can be waived. And there's consideration about trying to get a similar sort of amendation of our law passed in the upcoming legislatures. Okay. The other part is there are opt-outs. Individual practitioners can opt out if they are uncomfortable doing it. So it's not that a patient can come to me and go, you will do this for me because you must. I can go, no, I'm just too uncomfortable doing this. I, as an individual practitioner, opt out of doing this. But entire systems can opt out as well. And all they have to do is say, we opt out. They don't have to provide any sort of plan for how they will take care of people or anything else. They simply say, we opt out, and that means that entire system has opted out. And that usually includes not allowing their employees to participate in any material way in an end-of-life process, such as death with dignity. And so this also creates a sort of inequity for providers, because I, as an individual, provider, wherever I am, can opt out of doing a death with dignity process. But the thing is, if I'm embedded in a medical system that has opted out, I can't opt in no matter what my individual beliefs are about death with dignity or my relationship with that patient. So there is also a great inequity here in how this is handled on the individual and patient-physician sort of relationship arena. You can tell I have a great deal of passion about this.
Thank you so much, Dr. Dodge. That was a great explanation. So in your role as both a doctor who sees patients and through your role with End of Life Washington, can you tell me a little bit about what you've been seeing on the ground in terms of patients accessing the care they need with death with dignity?
So I got several answers to this because, of course, access is not a simple thing. So access starts with information. And the systems that opt out do not provide the information that there is such a thing as a law that is called the Death with Dignity law. And our estimates are less than 1 in 10 individuals facing the end of the life are informed that this is part of the option that they have. Okay. So there is one of them, a major thing is just we only get to end of life once in our life. So it's not like we've practiced this a couple times. So as I come to the end of my life, I'm hoping that I will get full information about what my options are at that point in my life. And again, we think probably only 1 in 10 get that the information that the Death with Dignity law is an actual option in the state of Washington. Okay. Access is also the geographic access. So we were hearing earlier from you, Dr. Siennis, as far as the people who are going to their local healthcare and the local healthcare goes, no, we don't do this, not because we can't do it, but we're told we shouldn't do it. And we have to now send you hours away to be doing this. And we have entire counties, the entire northwest portion of the state of Washington is basically almost entirely religious-based care And so that there is very little access to death with dignity from individual practitioners in the Bellingham, Blaine area with that. So we've got the geographic access. Access is timeliness. As in your cases, Dr. Sienna, something's happening and we need to take care of this rapidly. Well, as I said, people joining hospice, half of them die within 24 days of joining hospice. This is a timely sort of thing, particularly if we've got these time barriers in that. And if I, as your practitioner, go, oh, I can't do this here, let me refer you to someone, or good luck finding someone who you can find to do this for you. Your clock is ticking to the end of your life, and we don't know how well that this is going to fit with your reality. And finally, personally, access includes medical records. And I, as a practitioner working with End of Life Washington, have found multiple times where even though we're working with a patient who says, yes, I want you to have my medical records, a faith-based group will be reluctant, slow, or basically refuse to share the medical records with us so that we can establish whether or not this person will actually fit the legal criteria. So all of those levels of access are active currently and are problematic with the way the system is currently set up.
Thank you, Dr. Dodge. That is depressing but informative. So I had one other thing I wanted to ask you about, because you interact with the patients themselves. Can you talk a little bit about the impact when patients do not have access to a doctor who can provide them with these services?
Well, so imagine yourself to be in your doctor's office and you've got a cancer and you've been working with this provider for the last 2-3 years over treating this cancer. And your doctor is across from you and goes, oh, I'm sorry. We, at this point, do not have any other medical options to treat the cancer. Now, we're going to care for you, yes, but we can no longer reasonably think that this is a cancer that we're going to actually cure. And you as a patient then go, oh, well, okay, if that's so, what are my options? Well, how do you feel if you're not getting all of your options discussed with you at that point? Because the employer of your physician says that they can't offer you that information if you don't raise it with them directly. Or perhaps your physician goes, well, there is this thing with death with dignity, but I'm sorry, my employer, even though I would be willing to support you, my employer will not allow me to do this. So I know we've been working together with the last few years, but you're going to have to go elsewhere if that's what you're interested in. How do you feel as a patient sitting there? What's the impact on you to be told, well, now that you're dying, you've got to go someplace else, thank you very much. Now, shift gears for yourself and now think, here you are, you're this patient's daughter, and you're sitting next to your father, sitting and hearing this from their doctor. And you've been through this struggle, helping him get in and out to all these appointments and through chemotherapy. And you are now hearing from this provider who you've gotten to know as well, that she's quite willing to actually support the death with dignity, but her employer says she cannot do so. How are you as the daughter feeling in that moment? And I don't want to forget the provider who has fought with this patient through thick and thin, has taken 2 o'clock in the morning phone calls, who now has to say, I cannot go with you the final mile if this is what you choose. Now, these are not theoretical things. So in the state of Colorado, one of my previous practice partners was practicing there as a geriatrician inside a faith-based organization. Her patient, who she'd been working with in that way, was inquiring about the legal death with dignity in Colorado. And she said, well, I'm willing to support you in this, even though my organization will not allow me to be active with this. And she worked with him with that. And she was summarily fired from her position. Now, yes, this is in the legal courts, and the court has initially found in my compatriot's favor, but yet think about what the chill that puts through the medical system if you know that you can be fired for even supporting your patient in doing this. The impact is through all of that system and through the medical system as a whole, because we cannot provide standard care for our patients.
Thank you so much, Dr. Dodge. I think we will move to Cassandra. Thank you so much for joining us, Cassandra. Cassandra, also in somewhat of a unique position in that she has a personal story to share, and she's also the client service manager at End of Life Washington. Cassandra, to start us off, it's unique that you're the client service manager at End of Life Washington. What led you to that role?
Yeah, thanks. I want to echo everyone else and just saying thanks for the invitation to be here. I'm really grateful to be invited to be part of the panel. I think I have one of the best jobs, and this work chose me. I definitely didn't think I was going to be working in end-of-life care. I was living and working in Bolivia when my dad called to say he had been diagnosed with mild dementia. And I packed my bags and came home, where I jumped into the role of daughter, caregiver, advocate, all of the above. My grandmother had Alzheimer's, and it was really difficult and hard to watch. She died a stranger among strangers, and my dad was really clear that he did not want to live to the end stages of that disease. They live, and I grew up in Bellingham, where the only hospital is a Catholic system. And research shows that most healthcare restrictions mean that patients aren't informed of their end-of-life choices. So even if you do have options, the conversations aren't being had. And so it's on the individual to hear it from a friend or on the internet. Having a dementia diagnosis excludes you from Washington State's death with dignity law. So luckily there was an article in our local paper about a woman who chose to voluntarily stop eating and drinking, called VSED, in the early stages of her dementia when she had her capacity to exercise her control and choice. And my father clipped the article out of the paper and left it on the kitchen table, and it was like his eureka moment. It was his legal way. It was his way out. And for the next 2 years, my mom and I helped him prepare and get everything in order to be able to do this. The hardest part is knowing when to start. And my dad was really independent, really stubborn. And so when he lost his independence to go on a walk or play pool with his friends, it was time. In the summer of 2017 was when he began or stopped eating and drinking. And at the time, unfortunately, the restrictions of our local hospice prohibited them from getting involved, and therefore prohibited my dad from getting the support that he and we needed. And so he didn't get the symptom and pain management that he would have wanted. That being said, he died surrounded by family and really getting the end that he wanted after 12 days. But his experience is why I'm in this work. I want people to know that they have options, be supported in their choice, and be able to help write their final chapters.
Thank you so much for sharing that story, Cassandra. In your role as an advocate and as the client service manager, I know you probably interact with a lot of patients who are trying to seek care. Can you tell us a little bit about what you're seeing in the ground when patients are getting in touch with End of Life Washington?
Absolutely. So we are seeing increased barriers and limits on end-of-life care and choice. You've likely heard about the Virginia Mason and Franciscan merger. It's been in the news a lot recently. And once this merger goes through, it means that 50% or half of all hospital beds in Washington state will be part of a restrictive system, and that undeniably limits access and end-of-life choice. I want to be really clear, though, that people who come seeking death with dignity and access to the law really come from all religions and beliefs and walks of life. And so the right to end of life care should be available to everybody. You asked me how it manifested on the ground. And since we talked and I knew I was going to be on this call, I've had a phone call every day from a client saying they need help because their doctor is not allowed to participate in the death with dignity law. Last Friday, I had a daughter call on behalf of her mother who gets care at Virginia Mason. Her mother was really afraid that due to the merger, her end of life choices wouldn't be honored. She wasn't terminally ill and didn't have intention to hasten her death, but she was thinking ahead. She had heard stories about from her friends about them not honoring her do not resuscitate orders or the healthcare system that denied their choice or couldn't support death with dignity. We talked for about 30 minutes and I assured her that End of Life Washington would be there for them. And as a patient, they did have a right to advocate for themselves. But I left just feeling that like fear and sadness and lack of trust in the healthcare system, and it was heartbreaking. And I also got calls, like Dr. Wayne Dodge said, often this week of, my doctor says they are supportive, but they can't participate. So there you have a provider that wants to support their patient, wants to offer that continuity of care. And unfortunately, the healthcare system restrictions won't allow it. I do want to say that at End of Life Washington, we don't turn any clients away. Thankfully, to that amazing group of volunteer physicians, we're able to have referrals for terminal patients and support them if they can't access care in their own healthcare system. But the burden shouldn't fall onto a nonprofit organization, and people should be able to have their, like, how many people are not getting access to death with dignity because they're not hearing about it from their providers directly.
Thank you so much, Casa. And as one additional question, do you have any examples or stories that you'd like to share with the group of this type of situations you're seeing?
Yeah, so the thing that comes to mind is the delay that occurs when providers aren't able to participate. Like we talked about, there's that 15-day minimum waiting period built into the Death with Dignity Act. And we know that a lot of terminally ill patients don't have a lot of time. So in the moments when they should be focused on, with their families and their mental and emotional health, they're scrambling to find doctors. We have one case that comes to mind of a patient's provider couldn't participate. And so we found them a prescribing provider and a consultation was set up. And unfortunately, this person had brain cancer, which can affect capacity really quickly. And it was literally a day too late, where the day before the patient had capacity, and by the time they met with the prescribing physician, they did not. So they were unable to access the medical aid and dying. And then I also wanted to end by just sharing a story about a client on the eastern part of our state. And a special thanks to the volunteers that brought this story to my attention yesterday. Thank you. So like we've talked about, on the eastern part of the state, due to different geographies and population density, there are different areas where healthcare institutions will dominate huge geographic locations where restrictive policies will affect not only the healthcare center, but the hospice facility or the long-term care center in the area. So even if you do want end of care choice, you don't have anywhere to go. So I'm going to give this person a name and call them Emily. It's not their name, but Emily really wanted access to death with dignity and was living in an assisted living facility that didn't allow the ingestion of medication on the premises. And there was even a question at the time if, when receiving phone calls from the volunteer, if they were going to be able to speak freely about their wishes. The first thing that Emily needed to do was to have her doctor take her first oral request to begin that waiting period. The doctor was reluctant to take the request and support her choice. They eventually came around, but at that point the delays were too great and Emily's condition deteriorated rapidly. Unfortunately, in this case, she died a horrible death with a prolonged period of pain and suffering until she, at the very end, was transported to a hospital for IV palliative sedation. And it's just one example among many of people who want a good death and due to restrictive policies don't have those choices honored.
Thank you so much, Cassandra, and thank you to all of the wonderful panelists for sharing their stories and expertise today. Before we move to the question and answer period, I wanted to take a minute to call people back to the chat, where we are going to put in again the toolkit and also specifically the link to the action alert. If people are interested in doing the action alert right now, that would be great. It's sending an action alert to your lawmakers to ask them to take action to support patient access to care, specifically things like ensuring that providers are able to provide miscarriage and ectopic pregnancy care, and ensuring that there's government oversight of health system consolidation so that when these consolidations occur, communities aren't suddenly left without access to reproductive end of life and LGBTQ care. So I'm going to stop talking for a couple minutes to give those who are interested the opportunity to fill this out. Thank you all so much. And I want to say that this toolkit, which, as I mentioned, has an action alert, an email to send to people, ideas on messaging for social media, we are going to continue building this out with all of our allies and co-hosts to make sure all of you and everyone who wants to engage on these issues can, especially as we move into legislative session, where hearing from constituents and hearing from all of you is just so important, both to us and to lawmakers. We do have some questions that I want to get to. And so the first question I saw related to wanting to understand the difference when we're talking about health systems or hospital systems and individual providers. And that's a really great question. And you will see in the chat, apparently some people were getting errors in the action alert, and they have sent, and so we have another link in our chat that will send you to the right place. So you should no longer have a problem. Please go there. And in terms of the difference between healthcare providers, individual healthcare providers in the health systems, what we're talking about here is you can have individual healthcare providers like a doctor, a nurse, social worker who wants to provide care, but the health system that they're operating within prohibits it. So the hospital says you aren't allowed to do X, Y, or Z. So that's a distinction. You can have a willing healthcare provider, and in none of the laws we're talking about they are not directed in any way at the healthcare provider. No individual healthcare provider would be required to provide any service. It would just let them do it if they were willing and qualified to. There was also a question about providence and the broader issue of larger entities basically owning up facilities. And what does that mean right now? I want to speak to that a little in part of that question was, does it even matter if it's Catholic owned? And I think Cassandra got to this a bit in that when we're talking about these restrictions, we use Catholic health systems as an example, right? Because you have the ERDs there and they're clear. But these restrictions can also occur at other health systems. So what we're really looking at when we're looking at this is ensuring that all healthcare systems provide this level and access to care. The next question I actually wanted to pose to Dr. Siennis. One of the questions that was being asked related to, is there a better chance, success of care better in an instance when a woman's need to be transferred is or isn't over a long distance? And can you speak to that sort of from your medical perspective? What traveling a long distance can do to a patient when they're in this situation versus not?
Yeah, I think it's a multi-prong approach, right? So I think kind of what Dr. Dodge was saying, I think the first thing to think about is that you usually have a relationship with the doctor that you're seeing at the institution that you're at. And this is a very distressing situation. So from just a emotional standpoint, I think the need for transfer is always very distressing for patients, as well as we know, especially in situations where there's either really heavy bleeding or the bag of water has broken, you can go into preterm labor. And so that could also cause a lot of pain, cramping, discomfort, and that continues to become worse if you're having to wait multiple hours to go to a different hospital. So not only is the patient experience of just the whole experience of that pregnancy ending becomes more distressing, there also can be increased complications like more bleeding, higher risk of infection, the longer patients need to actually transfer to a different hospital system. And similar to what Dr. Dodge said, because some of these hospital institutions in certain counties are only religiously affiliated, that then precludes them that they have to go a far distance away to be able to go to a hospital that can take care of them.
Thank you so much. We have a lot of questions at this point, so we will only be able to go through a couple of these, but then we will also try to send written responses, I think, to others. I don't know how it works, but hopefully. But another question that I see relates to Kitsap County and King County and the proposed Virginia Mason CHI affiliation. So regarding Kitsap County, individuals talking about their fears relating to access to care now that so much of CHI, so much of the hospital system, the entire hospital system is CHI based. And then the Virginia Mason CHI affiliation would mean the clinic there would, one of the clinics there would also be CHI based. What I can say there is, I share your concerns. It is definitely problematic. I know Kitsap advocates are incredibly strong and loud spoken about this issue and are trying to take action. The ACLU and all the co-hosts are also working to ensure that patients still have access to care. And what I'd say is raise your voice. Make sure Virginia Mason understands how you feel about this and what you care about. One thing I would say regarding King County, because that was the other question, how will this affect King County? Obviously, Virginia Mason has a huge presence in King County. There's no question about that. We are lucky in King County that we will still have some entities that provide the full range of reproductive, end-of-life, and LGBTQ care. But people will have to be both very aware of where they can get the full range of care. And in many situations, you don't have a lot of control, especially emergency situations or sometimes end-of-life situations. You don't have a lot of choice of where you can go. So it will have an impact in King County. And I would turn it to Cassandra or Dr. Dodge to talk about from end-of-life care, the impact they think it will have on provider provision.
So we were fighting over who gets to talk. Again, as Dr. Siennis was saying, here we've got a longstanding healthcare system with a large number of longstanding patients, and suddenly a whole range of care is not going to be available to them. So this is going to definitely have impact. And I was seeing in the questions someone going, gee, I'm a Virginia Mason patient, you know, how is this going to affect me? And we go, it is going to affect you, and the exact how and to what level is yet to be determined. But no, there will be a definite impact where, again, we will have restricted the availability to this type of full care to a less than or about 50% of the total healthcare system within our geographic area. So Leah, there was another question I wanted just to briefly get to. And someone was saying, oh, can you get the lethal prescription and take it at home? Actually, that's the rule. The vast majority of our folks, in fact, are in their home as they want to be with their family around. So it is the exception when someone is actually in an institution. And what we're saying, though, is to get to that point where you can be using these medications in your home with your family around, you have to have a system behind you that will get you the access to the medications. In addition, I want to do the shout out to the End of Life Washington volunteers who are non-medical trained volunteers who support patients and families in their home to do this in a way that is really patient and family centered. Thank you all.
Thank you, Dr. Dodge. We only have a couple minutes left and many questions. Two that I wanted to highlight that I thought were important. One is, can we speak to LGBTQ plus care? So as we've mentioned throughout this, LGBTQ plus related care can absolutely be impacted by health system restrictions. In Washington State, we have had situations where patients seeking gender affirming care, such as surgery, such as hormones, have been denied care. We have seen situations where patients have not been able to access the insurance they need based on their gender identity or sexual orientation. This is a significant and real problem and absolutely relates to what we're talking about tonight. We are unable to have a panelist wasn't available for tonight. We have had other right to care events where LGBTQ plus panelists have been able to attend, and we hope to in the future. And the other question was, have these bills been dropped? Do they have bill numbers, and who are the sponsors? So the Protecting Pregnant Patient Act dropped last year, but it will have a new bill number this year. We are so lucky to have Representative Macri and Senator Kuderer as our sponsors for this bill. And we look forward to it moving forward this session with all of your help. The hospital oversight bill is a work in progress because it was not one that previously existed last year. I believe everyone who will be attending tonight can get updates as both these bills move forward so that you will be able to have bill numbers, sponsors, and all the other information you need. And I think we are just about at time. So I want to thank all of you for attending tonight, thank our wonderful panelists, and I hope you support these efforts as they move forward. Thank you.